All right, welcome back. Starting now our discussion of the leukocytes or the white blood cells, which will make less than 1% of the total blood volume. If you remember, 55% of the blood volume is going to be the plasma and 45% is going to be the red blood cells or the erythrocytes. Less than 1% is going to be the leukocytes and platelets combined. The white blood cells have the ability to leave the capillary via diapedesis, and they have two major characteristics that allow them to perform so. First, the chemotaxis ability. And a simple way to understand chemotaxis is like when you think of a dog. So how the dog will be able to find a person, you're gonna need to make this dog smell something related to the person you're looking for. So the same concept on here, the white blood cells have the ability to follow chemicals to find the origin of the infection. So at the site of an infection, many white blood cells are going to be releasing chemicals which will attract other white blood cells to the site of infection. And the ability to find those chemicals and to follow them is called chemotaxis. Also, another ability for the white blood cells that will allow them to reach the site of infection is their amoeboid movement. So they have a movement that will be like an amoeba. An amoeba is a single cell organism that has the ability to contract its body and to expand it like this for it to be able to move. So I have two very important characteristics as a white blood cell. First is chemotaxis, and the second one is the amoeboid movement. We classify the white blood cells into two major groups. Those are the granulocytes and the agranulocytes. And this is going to be according to whether I have cytoplasmic granules or not. For the granulocytes, those are the cells with cytoplasmic granules. We have three types of granulocytes. Those are my neutrophils, the eosinophils, and my basophils. The eosinophils will have cytoplasmic granules that love the part of the dye we call eosine. That's why we call them eosinophils. And this is the dye that stains red or pinkish color. So the cytoplasmic granules are stained red or pink. Compared to the basophils, they will love the basic dye, which stains the granules in a blue color or a purple color. That's why we call those white blood cells my basophils. They love the basic dye. Here, eosinophils, those will love eosine, which is the acidic dye. Compared to the neutrophils gonna contain both acidophilic granules, which are gonna be stained red, or pink, and also it will have basophilic granules which are going to be stained blue. That's why we call the cells here, they are neutrophils. They love neutrality. So again, the first class of white blood cells, which contain the cytoplasmic granules, those are my granulocytes. Second class of white blood cells, those are the ones that do not contain granules, so we call them A granulocytes. And those are like the lymphocytes and the monocytes. The most common type of white blood cells, those are going to be the neutrophils. Next is going to be the lymphocytes. Next would be the eosinophils. Next is going to be the monocytes. After that comes the eosinophils and basophils. A mnemonic here to remind you of the order of the white blood cells, by which ones are more common than which. So not letting monkeys eat bananas. Right, so most common is neutrophil, comes next lymphocytes, comes next my monocytes, next is going to be eosinophils, and finally my basophils. Starting with the first type of granulocytes, those are my neutrophil, and this is the most numerous type of white blood cells in your blood. They, as you see here on the slide, they don't have any definitive shape of their nucleus. The nucleus is neither spherical or cylindrical or looks like anything. So that's why we call the neutrophils the cell with many shapes of the nucleus. So we call them polymorph nuclear leukocytes. Poly means many, morpho means shape, and nuclear is nucleus, and those are the leukocytes with many shapes of the nucleus, polymorphonuclear leukocytes. They contain cytoplasmic granules that will take both the acidic and the basic dyes. So you're going to see some purple granules and the rest are reddish granules or pinkish granules. That's why we call them neutrophils, because their cytoplasmic granules going to accept both the acidic and the basic dyes. The granules going to contain hydrolytic enzymes and differensins. Hydrolytic enzymes are mainly for breaking down the ingested bacteria. So neutrophils are highly phagocytic cells. That's why we give them a nickname. We call them the bacteria slayers. Why do we call them bacteria slayers? Because they have a very high phagocytic ability. They can engulf the bacteria and they will break down this bacteria by their hydrolytic enzymes contained in their cytoplasmic granules. Eosinophils are going to be containing red stained granules, as you see here. So all of the granules are reddish because they are acidophilic, they did accept the acidic dye. And inside those granules, we're gonna have lysozyme-like chemicals. Their main function is to target and digest the parasitic worms. As the worms are too big to engulf, your immune cells will not be capable to engulf a worm, but they can engulf a bacteria. So what would I do here as an eosinophil? Eosinophils would be surrounding the worms and will start to release their chemicals, breaking down the worm on the outside of the cell rather than ingesting the worm, because the worm is too big to be ingested by one of the immune cells. Another type of granulocytes, those are the basophils. And again, basophils gonna contain basophilic granules. As you see here under the microscope, all the cytoplasmic granules are stained blue or purple in color. This tells you that you're looking at basophilic granules. They did love the basic dye which stains blue or purple. The main content of those cytoplasmic granules is going to be histamine, and histamine is one of the most potent inflammatory mediators. It mediates inflammation. And as we're going to learn, inflammation is one of the very important immunological responses which are going to be required to attract more white blood cells at the site of infection. Second class of leukocytes or white blood cells, those are my A granulocytes, and those are the white blood cells without any cytoplasmic granules. And this includes the lymphocytes and monocytes. We don't see any visible cytoplasmic granules. And a major characteristic here for both the lymphocyte and the monocytes that they have a specific shape of the nucleus. So the nucleus in the lymphocytes is going to be spherical and large, occupying most of the size of the cell. Compared to in the monocytes, they have a very characteristic shape of the nucleus. The nucleus is going to be kidney shaped, like this. Both of them are going to have a large nucleus because they are highly active immunological cells. As you see on here under the microscope, this is how the lymphocyte looks like. It has a large spherical nucleus occupying most of the size of the cell. Lymphocytes are mostly going to be kept in the lymphoid tissues. This includes lymph nodes, spleen, and bone marrow. Few of them normally circulate out in the bloodstream unless a person has an infection. They play a crucial role in the immunity. To give you an impression about how important are the lymphocytes for your immune responses, one type of the lymphocytes is called the T lymphocytes. I have many subtypes of the T lymphocytes. One of them is called the T helper cells. And T helper cells are the cells that get destroyed with HIV infection causing the acquired immunodeficiency syndrome or AIDS. And as all of you know, AIDS patients without having any treatment, they won't be able to fight any infection. And this is just due to the destruction of one type of T lymphocytes. We have two major classes of the T lymphocytes, which will be responsible for the adaptive immunity, as we're going to be discussing in the next chapter. Those are my B lymphocytes and T lymphocytes. We're going to discuss a lot about the lymphocytes in the next chapter. Monocytes, as you see on here under the microscope, the monocytes will have a large nucleus that looks like a kidney. Monocytes are going to be the precursor cells that will differentiate into the tissue macrophages. So normally in the bloodstream, what circulates is monocytes. Monocytes will be leaving the bloodstream and will be mobilized to stay within the tissues, and we call those are my tissue macrophages, like the Langerhans cells that we've seen in the skin, like the dendritic cells, like the neuroglial cells in the brain, and so on. So we have many macrophages living everywhere in the body. Like another example of tissue macrophages, like the ones in the lungs, we call those are the dust cells. We call the ones in the liver the Kupffer cells, and so on. All those are actually monocytes that did decide to migrate from the blood and to move to the different body organ tissues. They play a crucial role against viruses and intracellular bacterial infections, as well as chronic infections. The most important part about the monocytes and the macrophages, as those are the main activators for the lymphocytes. Those are the ones who will be presenting the antigens for the lymphocytes to recognize. Also, this is something that we're going to be discussing in details in the next chapter, but just to give you an idea about what we're talking about in here, if this is one of my cells and I've got a viral infection, so the virus is an intracellular infection. So the virus is taking over my cell. It's using all the resources of my cells to form copies of itself. This cell will rupture, will die, and the copies of the virus will be released to infect other nearby cells. The main function here of the monocytes will be to recognize that this cell is infected by a virus and engulf it and break down the infected cell as well as the viral particles. But again, those macrophages are located in the tissues. They do not travel around. So the macrophages living in my skin will not fight the same infection in my brain, will not fight the same infection in my lungs. So they are kept in a specific location. They are so difficult to move to the bloodstream to find the infection everywhere in the body. But who is going to be traveling everywhere in the blood are those lymphocytes. So the lymphocytes here, to be more specific, my T lymphocytes will come and will recognize, will learn the shape of the virus that they will be targeting. And they will become activated and will be released out in the bloodstream to find this virus or any infected cell with this virus and kill the cell and destroy the viral components inside the infected cells. So the ones that are actually killing the virus, targeting the infected cells are the lymphocytes, but they won't be able to do so without figuring out the structure of the virus. And the structure of the virus actually is going to be shown and presented by my tissue macrophages, which are the monocytes that have migrated to my organs. All right, this is just to give you an idea about how important are the tissue macrophages in terms of fighting viral infection. Leukopoiesis is the process by which we're going to be building up the white blood cells, and this requires many stimulating factors and hormones. This includes the interleukins like interleukin 1, 2, and colony stimulating factors like the granulocyte colony stimulating factor that will stimulate the differentiation of the hemocytoblast into granulocytes. Again, all blood-forming elements are coming from the same origin, which is the hemocytoblast, those stem cells living in my red bone marrow. The hemocytoblast has two main pathways in the differentiation to become a white blood cell. Either it become a myeloid stem cell or a lymphoid stem cell. Myeloid stem cells will be dividing and will differentiate into all the different types of white blood cells except for the lymphocytes. So if we're looking on here, they will differentiate into eosinophils, into basophils, into neutrophils, into monocytes. Compared to the lymphoid stem cell, it differentiates into just the lymphocytes. Why is it important to know the two differentiation pathways for the hemocytoblast? Because this is going to be the way by which we're going to be classifying the different types of leukemias. We classify leukemia according to two major factors. First one, according to the cell of origin. And second one, according to the level of differentiation. The cell of origin might be either the lymphoid stem cell or the myeloid stem cell. The level of differentiation, if the cell looked like a mature cell, we're going to call this as a chronic leukemia. And if it looked like the stem cells, it's going to be considered an acute leukemia. So if you work in a hematology department in a hospital, you will see on the board, they put ALL, CLL, CML, and so on. What this means? This means acute lymphocytic leukemia, chronic lymphocytic leukemia, chronic myelocytic leukemia, and so on. So what this means again, if it was a lymphocytic leukemia, this means it's coming from the lymphoid stem cell origin. If it's a myelocytic leukemia, it's coming from the myeloid stem cell origin. So it's one of those cells. If it was myelocytic, it's one of those cells if it was lymphocytic. What do I mean again by acute leukemia and chronic leukemia? Chronic leukemias look like the mature cells. They are less aggressive. They are more common in older age, and they are harder to cure. Those are the chronic leukemias. They are more differentiated. Compared to acute leukemias, they are much less differentiated. They look like a stem cell rather than a mature cell. As they are less differentiated. They look like a stem cell, so they are much more aggressive. They have a much greater proliferation ability. They can divide much rapidly. Remember, mature cells do not divide. Remember, the mature white blood cells, like the rest of the blood forming elements, they don't divide in the bloodstream. So acute leukemias, as they look like a stem cells, they have a very high proliferation power, so they will be much more aggressive. And most likely, they affect children at younger ages. And they are relatively easier to treat, to cure. You will see children, kids that got leukemia and they are cured from the leukemia. And you will see a 70, 80-year-old patient who is suffering from leukemia for 5 years. What is the difference here? Those kids with leukemia, they have a very aggressive disease. So you're going to see a lot of manifestation of the disease. Because the type of leukemia they have is an acute form of leukemia. Cells are less differentiated. They look like a stem cell. They are highly aggressive. Compared to chronic leukemia, they affect older people. They are much less aggressive. They will take time, chrono time. Why is it easier, do you think, to cure acute leukemia? Why is it easier to cure acute leukemia compared to chronic leukemia? What do you think? For those who are still here, please write your name in the chatting box. All right. So I still have somebody's awake. All right, great. So what do you think? Why do you think it's easier to cure the much aggressive disease and it's harder to cure the less aggressive disease? What do you think? Why is it easier to cure kids with leukemia than older patients with leukemia? What kind of treatment do those patients get? Chemotherapy. What's chemotherapy? Is this a form of radiation or a surgery? It's a poison, right? It's a poison. It's a poison that attacks what cells? All cells, right? But how come it affects the cancer cells more than the rest of the cells? Chemotherapy is given medication that affects all the body cells. But why do you think they have more effect on the cancers? Because cancer cells are rapidly dividing, so they will be uptaking more of the toxins here I'm giving to the patient, which are the chemotherapy. So as the cells are rapidly dividing, they will be uptaking much more of the medication I'm giving to the patient, so they will die because they will be uptaking a lot of those chemicals. Compared to chronic leukemia, are those rapidly dividing or not rapidly dividing? They are less aggressive. Slow. They are slow to divide, right? So would the chemotherapy be effective if I give it to a patient with a slowly growing cancer? Would it be more or less effective? What's the concept again of chemotherapy? You give medications. Those are simply toxins that will be reaching all the body cells. Why those chemotherapeutic agents will not be harming the rest of your body cells, or they harm the rest of your body cells to a less extent? Because simply the higher the rate of proliferation, the rate by which the cells are dividing, the more likely that those chemotherapeutic agents will kill them. So if I have a type of leukemia which cells are not rapidly dividing, so they will not be uptaking lots of those chemotherapeutic agents, and as a result, it's so hard to get rid of it. Does this make sense? Does this make sense? All right. All right, moving on to our third blood form element. This is going to be our platelets. The other names that we use for the platelets are thrombocytes. And from the word here, thrombocyte, what can we understand? Thrombus means blood clot, and cytes, those are cells. So what can I understand here? Those are cells responsible to form blood clot. So the first thing that we need to know about the platelets is that those are not cells. They are fragments of large cells called megakaryocyte. So those are not cells, those are fragments, tiny fragments of large cells called megakaryocytes. And they are not responsible for the formation of the blood clot. They are not forming the blood clot. They just initiate the formation of the blood clot. They don't form the blood clot. They just initiate the formation of the blood clot. They are required for the formation of the blood clot, but they are not building up the blood clot by themselves. They just initiate, they just activate the process of the blood clot formation. Those fragments of cells, they contain many chemicals that will help in the coagulation process. This includes the serotonin, calcium, enzymes, ADP, platelet-derived growth factor. All those are granular contents of the platelets. inside the platelets, those tiny granules inside the platelets going to contain growth factors, platelet-derived growth factor, calcium, enzymes, ADP, and so on. Thrombopoiesis or thrombopoiesis, this is going to be the process of the formation of the platelets. Platelets, again, like the rest of the blood-formed elements, are originating from the stem cell of all the blood-formed elements, which is my hemocytoblast. The hemocytoblast will differentiate into a megakaryoblast that differentiates into pro-megakaryocyte, then megakaryocyte, and again, the megakaryocytes will form those fragments that we will call the platelets. The hormone that triggers the differentiation of the hemocytoblast into a megakaryocyte for you to build up platelets is called thrombopoietin. So again, what are the different hormones that we've mentioned here that will have an effect on the hemocytoblast for it to differentiate? In order for me to build up erythrocytes, what was the hormone that allowed the differentiation? This is going to be our first question for the in-class activity for today. What is the hormone that allowed the differentiation of the hemocytoblast into erythrocytes? And we've got two main sets of hormones that will allow the differentiation of the hemocytoblast into leukocytes. So this is number 3. This is the second set of hormones that will be enhancing the hemocytoblast to differentiate into the leukocytes. And finally, number 4 is what is the hormone that would be enhancing the hemocytoblast to differentiate into the megakaryocyte that will form the platelets. Anybody can respond to the first question on here? What was the hormone that is gonna get released in response of hypoxia from the kidney to enhance the differentiation of the hemocytoblast into erythrocytes? What was the hormone that gets released from the kidney in response to hypoxia to enhance the differentiation of the hemocytoblast into an erythrocyte? Erythropoietin, exactly. If you see on here, this is the hormone that we have mentioned earlier today. Erythropoietin. Do you remember what are the different hormones that will be enhancing the hemocytoblast to differentiate into the different types of leukocytes? We did have 2 sets of hormones. What are those 2 sets of hormones that will allow the differentiation of the hemocytoblast into the different types of leukocytes? Anybody? So leukocytes are either granulocytes or agranulocytes. But my question here is, what are the hormones that did enhance the differentiation of the stem cells, the hemocytoblast, into either granulocytes or agranulocytes? We did see two sets of hormones. Those are interleukins. We have many types of interleukins. And the other set of hormones was the colony stimulating factors. So again, what are the two sets of hormones that will allow the differentiation of the hemocytoblast into leukocytes or white blood cells? Again, what are those two sets of hormones? Those are my 1C responses on here. What are those two sets of hormones? Interleukins, interleukin 1, 2, 3, and the colony stimulating factors. And as an example of the colony stimulating factors, we mentioned the granulocyte colony stimulating factor. All right. How about the hormone that enhances the differentiation of the hemocytoblast into megakaryocyte to form platelets? What is the name of the hormone that enhances the differentiation of the hemocytoblast into megakaryocyte to form platelets? Thrombopoietin. Thrombopoietin. All right. All right, so moving on to the hemostasis, or the blood clot formation, or the process by which I stop bleeding, stopping the blood loss. There is 3 phases here for hemostasis. First phase is the vascular spasm. And this is the first response to any injury of the blood vessel. So if I have a blood vessel like this, the very first thing in response to an injury, it's going to be the constriction of the vessel. The injured vessel, it will contract. Why do you think you will be contracting the injured vessel? First thing, to reduce the amount of blood loss. The second thing is to get those borders of the injured site closer to one another to reduce the gap at the injured site. So rather than having a large gap like this, when I contract the vessel, I'm pulling the borders of the gap closer to one another. The second phase of hemostasis is going to be taken place due to the activation of the platelets. So in an injured vessel, if you remember, your blood vessels are lined with one row of flat cells, simple squamous epithelium. We'll call this is my endothelium. And remember, underneath any epithelium, you've got the connective tissue to support it. So in an injured vessel, I will have a disruption in my endothelial lining, exposing the collagen fibers of the connective tissue. Circulating in my bloodstream, I've got those fragments of the cells called platelets. Once they get exposed to the collagen fibers, they will stick to the collagen fibers and will start to release their granular contents to the outside in the bloodstream, recruiting more platelets and attracting more platelets to the site of injury. As more platelets come and become activated to attract more platelets and more platelets come to become activated, I will fill the injured gap, as you see on here, by platelets. And this is going to be the second phase of hemostasis, which is the formation of a platelet plug or platelet plug formation. Is this my blood clot? Is this my blood clot? Is this my blood clot? It's not a blood clot yet. It's not my blood clot. This requires more stabilization because the platelet plug that I did fill the gap with, it's not stable. With very minor trauma, it can be dislodged from its place. So it's not something that I can rely on to seal the injured vessel. So this requires me to pass through the third phase, which is the coagulation. Or the blood clot formation. We have two pathways for the blood clot formation. First one is called the intrinsic pathway. The intrinsic pathway starts with the activated platelets. The activated platelets will be releasing chemicals, as we've mentioned earlier, and those chemicals gonna be activating plasma proteins that are present in the blood. The first plasma protein, the first coagulation factor that gets activated is called coagulation factor 12. So we give them names and we give them numbers. We are only concerned with the numbers. So the first coagulation factor that gets activated is going to be coagulation factor 12. It becomes activated factor 12. Activated factor 12 gonna activate another coagulation factor, which is coagulation factor 11. That becomes activated factor 11. So this A here means activated. Activated 11. Can you guess what is the next factor that it will activate? So we started with factor 12. It activated factor 11. So what do you think factor 11 gonna be activating? So you will think it's going to be activating factor 10, but actually we're going to be skipping factor 10. It activates not factor 10, it activates factor 9. We're going to just skip factor 10. All right. So most of you now and on the exam will think factor 11 activates factor 10. It's not. It activates what factor again? Not 10, not 10. It activates 9. Factor 9 activates what factor do you think? This is no trick. Factor 8. All right, so again, what did we mention so far? We mentioned that we have two pathways for the blood clot formation. We started with the intrinsic pathway. Intrinsic pathway, what do I mean by intrinsic? What's inside? We start from inside the blood vessel. This is what we mean by intrinsic pathway. We started by having what that have been activated by platelets. So the platelets that got activated are going to be releasing chemicals which will cause the activation of factor 12, that activates factor 11, that activates 9, that activates 8. Both factors 8 and 9 will form a complex, and they will activate factor 10. All right. So again, activated platelets that activate 12, that activates 11, activates 9, that activates 8. 8 and 9 will activate factor 10. So they give them numbers according to when they got discovered. So the first ones that got discovered, they give it a number, factor 1. Second one, factor 2, and they don't change those numbers. All right. So those numbers are given not according to their action, but according to when they were discovered. All right. All right, so starting here with factor 10, this is going to be what we call the common pathway. So both intrinsic pathway and here, this is going to be the extrinsic pathway. Gonna share the common pathway. So let's have a look at the extrinsic pathway. What I mean by extrinsic pathway, outside of the vessel. What's outside of the vessel that will cause the coagulation to become activated? The injured cells, which are located outside of the vessels, they will be releasing what we call a tissue factor. It's a different color on here. What was the last factors that we stopped at before we reach factor 10? What was this factor on here? It's factor 8, right? So tissue factor activates what comes next is factor 7. becomes activated 7. Both tissue factor and activated 7, they both will form a complex and they will activate factor 10. So again, what activates coagulation factor 10? Either the complex of both activated 9 and activated 8, or a complex of tissue factor and activated 7. This is what activates coagulation factor 10. Coagulation factor 10 here, when activated along with factor 5 that becomes activated, becomes pro-thrombin activator. So what do you think? Is a pro-thrombin activator gonna be doing? What do you think this hormone called pro-thrombin activator is gonna be doing? From its name. So if, for example, I'm called the power activator, so what would I be doing? I would be activating power, right? So what do you think is the function here of the pro-thrombin activator? Is to do what? To activate what? I'm called pro-thrombin activator. So what am I activating? Somebody? Pro-thrombin activator. What do you think is going to be activating? Pro-thrombin. Thank you. So pro-thrombin under the effect of the pro-thrombin activator, which resulted from the activated factor 10, remember before. So what do you think pro-thrombin will be activated in? Just from the name, pro-thrombin, it gets activated into what? Into thrombin or thrombin. Pro-thrombin is factor 2, coagulation factor 2. Thrombin function is to transform the soluble form of the fibers called the fibrinogen. This is a soluble form. When it becomes activated, it becomes insoluble, and the insoluble form of it, it's called the fibrin. This is my insoluble form. And the fibrin is going to be forming threads. Is this a blood clot? Is this the blood clot? Is this the blood clot? Those fibrin threads on here? Not yet. those fibrin threads need to be attached to one another, forming a fibrin mesh. I need to form a mesh of those fibrin threads. And this requires another coagulation factor, which is factor 13. Factor 13 here is going to become activated by the thrombin. Activated 13 is the one who attaches the fibrin threads to form fibrin mesh. This is my blood clot. A mesh formed of fibrin threads that seals the injured site. So again, what are the phases of hemostasis? First phase of hemostasis was vascular spasm. I constrict the blood vessels that got injured. I get the borders of the injured site closer to one another. I reduce the amount of blood loss. Next is going to be the platelet plug formation. I form a platelet plug, a temporary seal until I form a blood clot. And the third phase is the coagulation, or the blood clot formation. Again, how many pathways for the coagulation? How many pathways for the blood clot formation or the coagulation? I have two pathways. Intrinsic pathway and extrinsic pathway. Intrinsic pathway, I started by activated platelets. Activated platelets releasing chemicals that will activate factor 12, which activates factor 11, that activates factor 9, that activates factor 8. Activated 8 and 9 will form a complex to activate factor 10. Extrinsic pathway. What I mean by extrinsic means it's taking the initiating factor is from outside of the vessel. What's outside of the vessel? It's the injured tissues. We call the chemicals that would be released from the injured tissues on here is my tissue factor. Tissue factor activates again factor 7. Both tissue factor and activated factor 7 will form a complex that activates factor 10. Activated 10 will result in formation of the pro-thrombin activator. Again, what pro-thrombin activator is going to be activating? What pro-thrombin activator is going to be activating? Pro-thrombin. And when you activate pro-thrombin it gets activated into thrombin. And what is the function of thrombin again? it's going to be transforming the soluble fibrinogen into its insoluble form, which is my fibrin. So I will have insoluble fibrin threads like this. Again, in order for me to build up a blood clot, I need to get factor 13 to arrange those fibrin threads and form with them a fibrin mesh. This is going to be my blood clot. So your blood clot, it's not formed by only the platelets. What's formed only of platelets, it's the platelet plug. Blood clot, it's formed of fibrin mesh. And yes, embedded between those fibrin threads, you're going to still have platelets. Something I want you to notice on here in the coagulation pathway is that almost every time you're going to be activating a coagulation factor, the activation process requires calcium. And remember last session when we discussed the functions of calcium, one of the functions of calcium that we've mentioned is it's essential for normal blood clot formation. And this explains why we need calcium for the blood clot formation, because it's required for the activation of many of the coagulation factors. So what happens? After that, I've got my fibrin mesh, but this fibrin mesh is not stable. I need to make it more stable. This will take us to our next step, which is the blood clot retraction. What's the blood clot retraction? I will be pulling those fibrin threads closer to one another. For this blood clot to become tougher and much more stable. How can I retract the blood clot like this? The platelets embedded between the fibrin threads will contain actin and myosin filaments, like the ones that we did have in the muscles, which will allow the platelets to contract, pulling those fibrin threads closer to one another, and will be squeezing out the serum. So serum, the remaining part of the plasma that got trapped between those fibrin threads of the fibrin mesh, will be squeezed out, making the blood clot much stronger and more stable. All right, so here looking at the blood clot retraction, and this is something that you normally notice. So if you got injured, what happens to the blood clot after a few days? Will it shrink or does it expand? Something that you will notice that it shrinks over time. Actually, it shrinks within 30 to 60 minutes. It shrinks within 30 to 60 minutes. Why? Because of the blood clot retraction, which is taking place, squeezing out the serum and pulling those fiber threads close to one another. Any questions? Any questions? All right, so I will stop at this point today. Just a quick reminder.